First of all, it's a great pleasure to be here with you and to be the part of this important and great event. So, before I go to the cardiovascular prevention, I wanted to stop on some statistical data, and I wanted to notice that the global population of men and women were raised from 2000 to 2022. And as you can see, the population of men is slightly higher than population of women. On this slide, you can see many familiar faces, and as you know, all these people have been suffered from cardiovascular diseases. We have plenty of cardiovascular diseases. They are similar, but they have different own characteristics in progression, treatment, and prevention, including differences based on gender. And there is strong epidemiological evidence that men and women face different risks and have different outcomes of cardiovascular diseases. Heart attack and coronary heart disease rates increase with age, with fewer cases in younger women, but balancing out in older age. Ischemic heart disease is more frequent among the men population, but it can be frequent in women after menopause, and it develops in women 7-10 years later than in men. If we talk about atrial fibrillation, it's less common in women, but it's higher risk factor for women regarding the thromboembolic events. But I think you know that we have new guidelines for management of atrial hypertension or atrial fibrillation in 2024, presented by European Society of Cardiology. And they presented that we have some changes in scale which we use to assess the thromboembolic events in people with atrial fibrillation. So the female sex is not a risk factor anymore in this scale. If we talk about diabetes, especially type 2 diabetes, it raises cardiovascular risk 3-4 times in women and 2-3 times in men. Also about heart failure. Heart failure is more frequent among men, but if we talk about heart failure with reduced ejection fraction. If we talk about heart failure with preserved ejection fraction, it's more frequent among women, but develop later than in men. We have plenty of risk factors of cardiovascular diseases, and we can divide them into 3 groups. It's major risk factors that affect both men and women, female-specific risk factors, and male-specific risk factors. Major risk factors that affect both men and women, they are elevated blood pressure or hypertension, cigarette smoking, diabetes, overweight and obesity, raised cholesterol. If we talk about female-specific risk factors, they are pregnancy, hypertensive disorders of pregnancy, gestational diabetes, placental disorders, other pregnancy complications, polycystic ovary syndrome, and menopause. If we talk about male-specific risk factors, it's erectile dysfunction. As you can see on this slide, there is illustration, death rate from cardiovascular diseases by risk factors, and high systolic blood pressure or arterial hypertension and hypercholesterolemia and diabetes are three main causes of death in patients with cardiovascular diseases. We start from elevated blood pressure. As you can see, in 2019, the worldwide age standardized prevalence of hypertension defined by systolic blood pressure higher than 140 and diastolic blood pressure higher than 90 or taking medication for hypertension was 32% in women and 34% in men. Also, I wanted to notice that the arterial hypertension is the prevalence of arterial hypertension, as you can see, is higher than in men, but in women after menopause, it tends to be higher. Increase. So after 65 years, the most of patients with hypertension are women. On the slide, you can see risk factors that influence cardiovascular risk in patients with hypertension. It is data from European ESH guidelines for management of arterial hypertension 2023, and we know that we have three groups of risk factors. The first group is risk factors included in SCORE-2 and SCORE-2-OP scales. The second group is established and suggested novel risk factors, and the third is additional clinical conditions or comorbidities. So we can say that in this some of these risk factors are sex specific, especially sex or gender. Yes, family history of premature cardiovascular disease, if we talk about age, adverse outcomes of pregnancy and menopause. And in new guidelines of ESC 2024 for management of patients with arterial hypertension, they also talk about risk modifiers, which we have to assess when we certificate the risk of patients with arterial hypertension. So there are two groups: sex-specific modifiers and shared modifiers. Sex-specific, they are gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, one or more stillbirths, or recurrent miscarriage. On the slide, in the right corner, you can see the Kaplan-Meier survival function, and it showed a significantly lower incidence of total cardiovascular and non-cardiovascular mortality and of all cardiovascular, cerebrovascular, cardiac, and coronary events in women than in men. In the back of slide, you can see another illustration. The hazard ratios expressing the risk of the composite cardiovascular endpoint in relation to the 24-hour systolic blood pressure and the risk of all cardiovascular, cerebrovascular, and cardiac events in relation to the nighttime systolic blood pressure were higher in women than in men. Therefore, the absolute cardiovascular risk was lower in women than in men, while the increase in risk associated with 24-hour and nighttime blood pressure was steeper in women than in men. And I want to notice that proportion of events potentially preventable by blood pressure lowering may therefore be greater in women, making a wide implementation of ambulatory blood monitoring in women desirable. If we talk about hypertension-mediated organ damage, we have four organs, yes, it's heart, and if we talk about heart, especially left ventricular hypertrophy, it's more prevalent and less modifiable by antihypertensive treatment in women than in men, and women with hypertrophy, left ventricular hypertrophy, had about the same cardiovascular risk as men. And left atrium dilatation also more common in women than in men with hypertension. If we talk about arterial stiffness, both genders, both sexes experience an increase in arterial stiffness with age, with women showing a more rapid increase after menopause. So, older women experience greater aortic stiffness and arterial pulsality than their male counterparts, seemingly contributing to isolated systolic hypertension, uncontrolled hypertension, heart failure with preserved ejection fraction, and aortic stenosis. These conditions are more common in women. If we talk about albuminuria and chronic kidney disease, I want to say that it's lower in postmenopausal female individuals than in male individuals, and men were more sensitive to hypertension-induced changes in kidney function over time than women. And in women, there is less rapid decline in renal function. Outcomes. In the INTERHEART study, the increased risk of myocardial infarction associated with hypertension was greater in older female than in male patients. Also, hypertension-related outcomes may occur at lower systolic blood pressure levels in women. We should start therapy in women in more lower systolic blood pressure levels. The increase in risk of heart failure is greater in female than in male individuals, especially heart failure with preserved ejection fraction. According to one Norway study, the 55-70% of patients with heart failure with preserved ejection fraction were women. Non-medical interventions, it's an important part of treatment of hypertension, and in the DASH trial, dietary sodium restriction induced pronounced blood pressure reductions only in female individuals. If we talk about physical activity, meta-analysis of 93 trials assessing the impact of a structured aerobic exercise therapy found that exercise induced a greater blood pressure reduction in male than in female participants. Medical intervention. Female patients are less likely to receive antihypertensive therapy than male patients for comparable blood pressure values. Adverse effects from antihypertensive drugs are reported more often for women than for men, and there is no consistent data on sex differences in the efficacy of hypertensive drugs. I wanted to talk about example. I don't know how in China, but in Kazakhstan, if we have family, husband and wife suffered from arterial hypertension, often the husband is more adherent to therapy than his wife. Why? Because wife every day, every morning, she gives him medication and control that he took it. But she also often forget to take her medication. The next risk factor is raised cholesterol. Most of the large longitudinal studies with measurements before, during, after, and menopause transition show changes in cardiovascular risk factors, including weight gain, visceral adiposity, adverse effect on lipids. And in the World Health Organization CVD risk chart working group report, both sexes had similar risk for fatal and non-fatal myocardial infarction, coronary heart disease, and stroke per 1 millimole per liter increase in total cholesterol. Also, we have to remember that lipids also vary during the menstrual cycle in women, and with increasing during pregnancy in levels of total cholesterol and triglyceride. The next risk factor is obesity and overweight. And I wanted to stop on statistical data. The prevalence of obesity in adults in 2016 in China was 6.6%. If we talk about difference between men and women, the obesity more frequent, more prevalent in women than in men. In Kazakhstan, the prevalence of obesity is 21%, too much higher than in China, and too much higher in women than in men. And according to some studies, women are more likely to have obesity because they don't do physical activity, maybe it can also stress. And also one example, I have a colleague, she's cardiologist, she PhD student, also she has family, 3 children, and while she doing her research, working, looking after her children, her husband doing sport, learning English, living his best life, and he has not obesity, but she's obese. The next risk factor is cigarette smoking. If we talk about a statistic, in China, the percent of adults who are smokers are 25.6%, and the absolute majority are men. It's true for Kazakhstan. The prevalence of smoking is 23.2%, and the majority of smokers are men. And key points of my presentation: cardiovascular risk prediction based on traditional risk factors over a 10-year span underestimates risk in women. Lifetime cardiovascular risk and treatment benefit may be preferable approaches to tailoring cardiovascular disease prevention in women. Female-specific risk factors such as pregnancy-associated disorders should be considered to promote earlier cardiovascular risk factor assessment. Female sex influences lipids during transitions, such as pregnancy, breastfeeding, and menopause. After menopause, women experience a worsening in the lipid profile, potentially contributing to accelerating cardiovascular risk. The impact of several lifestyle-related risk factors is disproportionately greater in women than in men. Adverse change in weight, lipids, blood pressure, and glucose metabolism with menopause transition highlight potential accelerating cardiovascular risk. Symptoms of atherosclerotic cardiovascular diseases in women are underappreciated and are under-recognized. Women have a higher burden of microvascular dysfunction than men. For all presentations of atherosclerotic cardiovascular disease in women, delayed or missed diagnosis is common and contributes to undertreatment. Thank you very much.